Hello, this is David Altschuler from the University of Michigan, and today I'll be talking about our chapter, Central Nervous System Embryonal Tumors. The objectives of this chapter will be to understand the heterogeneous nature of embryonal tumors of the central nervous system. We will also review the management of a case of a patient with medulloblastoma, which is by far the most commonly encountered embryonal tumor subtype. We will also discuss complication avoidance and postoperative management, as well as adjuvant treatment strategies. Embryonal tumors are a complex group of hypercellular, poorly differentiated, and mitotically active neoplasms with features reminiscent of the embryonic central nervous system. This heterogeneous group includes medulloblastoma, atypical teratoid rhabdoid tumor, embryonal tumor with multilayered rosettes, CNS neuroblastoma, CNS ganglioneuroblastoma, medulloepithelioma, and CNS embryonal tumor not otherwise specified. Embryonal tumors are uncommon, accounting for 1% of all CNS tumors. Medulloblastomas are by far the most common embryonal tumor, occurring 10 times more frequently than all of the other tumor subtypes combined. While medulloblastoma is most often diagnosed in patients aged 4 to 6, other embryonal tumors occur in younger children. For instance, 65% of CNS embryonal tumors other than medulloblastoma occur in patients younger than 5 years of age. Different tumor subtypes are characterized by distinct molecular features. For instance, atypical teratoid rhabdoid tumors have inactivation of SMARCB1 or INI1, which is a key component in the switch-SNF chromatin remodeling complex. Atypical teratoid rhabdoid tumors are characterized histologically by spindle-shaped rhabdoid cells with eccentric nuclei and intracytoplasmic inclusions. They are most commonly seen in patients younger than 3 and occur with equal frequency in the supra- and infratentorial compartments. ATRT accounts for 1 to 2% of all pediatric tumors, but over 10% of all CNS tumors in infancy. Embryonal tumor with multilayered rosettes is a tumor type that is characterized by multilayered rosettes and have amplifications and rearrangements of the microRNA cluster C19MC at chromosome 19q13.42. Two-thirds of these cases are supratentorial, while a third involve the cerebellum or brainstem. Medulloblastoma is the most common CNS embryonal tumor and is the most common malignant brain tumor of childhood, accounting for up to 20% of all pediatric brain tumors. While it used to be regarded as a single heterogeneous entity, current consensus recognizes 4 biologically distinct subgroups. These include the Wnt, sonic hedgehog, group 3, and group 4 tumor subtypes, all with unique genomic, clinical, and prognostic features. We will now review a clinical case of a posterior fossa CNS embryonal tumor. A 2-year and 9-month-old presented with 3 weeks of head tilt, unsteady gait, and morning vomiting. When he was unable to walk unaided, an MRI of the brain in the emergency department demonstrated a 4-centimeter heterogeneous, contrast-enhancing solid and cystic mass of the 4th ventricle with supratentorial hydrocephalus. The patient's initial imaging is shown here with axial contrast-enhanced sequence on the left and sagittal sequence on the right, demonstrating the contrast-enhancing mass in the posterior fossa with resultant mild tonsillar herniation and obstructive hydrocephalus. Based on the patient's history and imaging, CNS embryonal tumors must be included in the differential diagnosis, with medulloblastoma being the most likely. Also possibility is ependymoma, and less likely pilocytic astrocytoma or choroid plexus papilloma. The initial treatment plan for this patient included surgery in order to obtain a diagnosis and restore CSF pathways. Maximal safe surgical resection is the primary objective. However, if this cannot be achieved safely, near total resection with less than 1.5 centimeters squared residual remains beneficial. A tumor in this location is accessed via suboccipital craniotomy, which allows for a telovelar or transvermian approach to the tumor, depending on patient-specific anatomy. Other preoperative considerations must include CSF diversion, either via endoscopic third ventriculostomy or external ventricular drain placement. Neuromonitoring, including somatosensory evoked potentials and cranial nerve monitoring, may be used in cases where there's tumor adjacent or invading the brainstem in order to prevent neurologic deficits postoperatively. There are a number of factors to consider in order to minimize surgical risk. The presence of occipital and marginal sinuses, particularly in pediatric patients, must be considered during dural opening in order to avoid sinus bleeding. Posterior circulation arterial anatomy may also be displaced by the tumor. Care must be taken to reduce the degree and duration of cerebellar retraction during surgery. Brainstem injury is always a concern where there is clear evidence of tumor invading the brainstem. Cerebellar mutism is one of the most feared complications following resection of posterior fossa tumors. This syndrome describes delayed onset oropharyngeal apraxia, including lack of speech, hypotonia, ataxia, and emotional lability. This syndrome, once thought to be quite rare, has been demonstrated in as many as 30% of patients undergoing resection of a medulloblastoma. Finally, care must be taken to obtain a watertight dural closure and good fascial closure to avoid the risk of postoperative spinal fluid leak. This is our patient's early postoperative imaging demonstrating gross total resection and minimal residual blood products in the resection cavity. Adjuvant evaluation and treatment includes lumbar puncture to detect disseminated disease, as well as imaging of the brain and spine for staging. The heterogeneity of CNS embryonal tumors has prevented the establishment of a single chemotherapy or radiation protocol. However, chemotherapy and craniospinal radiation remain mainstays of therapy. Our patient received induction followed by multi-agent chemotherapy. Radiation was avoided in his case given his young age. Factors associated with prognosis include the extent of metastatic disease, extent of resection, age of the patient at diagnosis, as well as the histopathology and other molecular characteristics. This is a representative example of our patient's 1-year postoperative MRI. Patients with CNS embryonal tumors have a poorer median overall survival in general than patients with medulloblastoma. A large database study demonstrated 5 and 10-year relative survival rates of 64.9 and 52.1% respectively for adult patients with medulloblastoma. In conclusion, CNS embryonal tumors are a heterogeneous group of high-grade neoplasms, most often affecting young children and infants. Treatment options include surgical resection and chemoradiation. Outcomes are determined by histologic molecular diagnosis, as well as extent of disease, extent of resection, and age at diagnosis.